Hello, this is Param Eftekari, the co-founder and EVP of Research with the Health Tech Council. I'm joined today with Claus Nielsen, the International Business Development Manager at Delta. Claus, thanks for joining us today. I want to start by asking you what you think the biggest difference is between the Danish and US health IT strategy.
Yeah, when I look into, now you have to know the Danish system is highly advanced in terms of let's say, the deployment of using, first of all, electronic communication, the deployment of electronic communication between all actors like pharmacies, GPs, hospitals, home care facilities, assisted living facilities. They all, despite they are in different organizations, they are private and public actors, using the same infrastructure. And they're also using, in most parts, highly advanced EVR systems that is now being rolled out in the, let's say, the third generation. It's all done in the private secured health data network where you use the communication, and we are now moving into, let's say, the mobile revolution of healthcare. That is, I think, the single most interesting development, because we can't just adopt what you see right now in the, let's say, the health tool world, the fitness world. When I look into the US, I see a system, and I see some of the discussions we're using that are being used in the US. US is a vast country. It's have a fragmented healthcare system that is split up by lots of different actors: private, public, Medicare, insurance, all kind of reimbursement systems. They can have an ecosystem inside Kaiser. But if you are changing job and have another insurance, you're out. The data goes off. There's no interoperability. So it's pretty much where Denmark was in, let's say, in the 90s, early this century maybe. And the discussion you have now, when I see stuff, it's like we had that discussion about having apps that were working independently in, let's say, a mock-up from some kind of, let's say, innovation people. As was shown in the San Francisco Health Tour, they were silos of solutions, not used. So what I see now is there's a big challenge for the healthcare system, because what we do in the US and Denmark is we have these old legacy systems. We have tried to transform that. It takes time, but we're doing that in Denmark with this middle-out approach, where we started to doing our forms, which is defining the standards nationally, centrally. We're not doing that anymore. We have made this middle-out approach. We're working together, finding all the actors, and then the government sometimes comes in, put in some, let's say, here we need to have the regulation, here we need to enforce some kind of standards when it's needed, if you can't do it voluntarily. So we had a good, but not so fast working process. When you go to the US, for me it's like, when I see people that lose their job, they're also, trying to say it,
losing their healthcare.
What?
Losing their healthcare.
Losing their healthcare. That is not a situation in Denmark, and we talk about a system that is so efficient because we have less bureaucracy, less paper. We don't use paper. You can get in Denmark, you can get divorce digital. You can get, you use the API for that. You sell your house, all court documents are digital. You get no tax papers, it's digital. Your health books, you access your medicine information, it's all digital. So that's why we are one of the top 3 leading government countries in the world. And this also influences the healthcare system.
Yeah.
So we are, in many ways, we are ahead of the US. And what the US needs to find out is that they will not be able to change that system. So they will be much more, let's say, challenged into finding ways to get people to adopt interoperability standards. The only way you can make the data come from, let's say, whatever people measure on their body, on their Fitbits, on their, like my ECG recorder I have right here on my, that one? That I show? My little ECG recorder. Alright, I can't take it out now, but it's like this. That when you have these data, they should be available. We collect them, we can collect them with a lot of other data, and this is, I think all the players are getting in the US is talking about big data.
Yeah.
that potential is unleashed. Because when we get all the data in, when I can combine for my diabetes, my night fuel band that is now a plug-and-play device that can plug into I can send these data, and I can monitor my diabetes logbook for my little kid when he's playing around, and we can see it. When these data comes in, they're analyzed together with a lot of other patients that is like him, not a patient like me, but like him. Then we create something fantastic. So this is where we see we are in the start of this. This is the first part where I think the U.S. government needs to support the public and private market wherever they can by enforcing some of the standards that is available. One option for, let's say, mobile health is to continue health like guidelines, and Denmark adopted as the first country. Now Singapore follows. Normally US will come later to that step, but I hope they're also looking into that, because then we can get that mobile revolution to transform healthcare.
Well, and the healthcare ecosystem has so many moving parts, it's already so complex, and I have even more complicated IT ecosystem coming into play, and it's really about finding the balance and how these different technologies support the different objectives and mission of healthcare, be it through informatics, be it through new communication styles with mobility or information sharing or whatnot. So I mean, you're absolutely right. I think there's we've dipped our toe into it, but there's still much work to be done, and that's why we're excited to have Denmark, several Danish folks here today talking about the work that you guys are doing.
I think one of the basic milestones you need to achieve in the US is to get, let's say, if you have EHR systems built on let's say the same platforms and standards, like it pretty much looks like everybody's working towards IET and HL7, which are the communication protocol and the profiling, and then if these vendors are built onto that, so they can also accommodate in the different really various systems. Really, it's a big market in the US, and it's really complex. But if they can establish some kind of reference model for how to do that, then you can also easily adapt let's say that you're pushing the healthcare and put it out in the homes, out in the neighborhoods.
Yeah. True patient-centric care.
But you're not. Yeah, that we are not in Denmark, but we are, let's say, paving the way to have some learning experience. And I think we can use, US can use that, because it's much easier to make a pilot project in a little area with 5 million people, still having all the same problems like the US federal level, local level, the same problems, but in a minor scale. Before you scale up something in the US, and you cannot transfer all of them, because our systems are different. But I think that can you get that EHR systems to rapidly change, have more GPs using ICT, have electronic communication, have more centralized data of medicine, have access to services, web services that is securely stored, probably in the cloud. Then and I can take what I have on my iPhone or smartphone, whatever I use for a device, that it can securely connect the data I collect into my doctor, and the next phase will be automatic algorithms detecting a lot of advanced stuff that we don't see yet. Will be coming in the next 5-10 years.
But like you mentioned, the knowledge is all in the data. We just have to learn to pull it out. Yeah, I agree. So those are all great points. You know, one of the things you mentioned in your presentation to close is the value of collaborative environments, such as what we're doing with health tech. So I want to know, what do you see as the value of our organization and what we're providing to the community?
Yeah, but I was really honored to come here to Chesapeake and speak, and then of course I was curious, because who were health technology, and I found out it was new, but it was people coming, working with problems that for long have been already challenging, let's say, the governments around the world with the cloud. Can I have my personal data in Denmark stored in relation? We do.
Yeah.
We do. It's a discussion. Is it allowed for using Google apps to have public data? How do you do that? So we have a lot of all these discussions, endless discussions. Who owns data? What happens with the cloud security issues? This is also something that is highly relevant for the healthcare system. But I think they have been so busy in just, let's say, going to remove more and more paper. They haven't gotten yet to that point where you get digitalized, lean healthcare system. Even the ones we admire, like the Kaiser system in the US, they're still also struggling to combine all the data, but they're doing what we also want to do with that.
Sure.
So when we look into that, you have so many resources and knowledge, and now you're moving in to make daughter out of your big group.
Yeah.
To work with these topics. And I think if you can match this and try to get more understanding of what happens when we go mobile and go cloud, and what happens with security, and how can all these app companies, I would call it the app hell, where you have too many apps, but how can we help them to get data the right way?
Absolutely.
A lot of this is interesting. So I think it's healthcare is a challenge, and we have to transform our legacy systems, and we have to rapidly adapt to these opportunities of the, let's say, the mobile revolution that's really hitting us full time now. And I see emerging markets like Africa, which have no healthcare records at all, they move directly into mobile. Maybe we can face in our old Western civilization that the emerging markets will take over fastly on adopting mobile health.
Yeah, I think we shall see. Well, Claus, thank you so much. And yeah, it's very interesting. And I'm glad. Thank you for joining us, and we'll have to see you in our April meeting as well.
I hope.
Sounds great. All right. Thanks, sir.